Next is Dr. Warhadpande from our IR department. He's a clinical assistant professor in radiology and associate director of the IR Medical Student Education. He gave the first talk I've heard on PAE at the Michigan Urological Society, and we really had a great debate. He's also the first radiologist who called me and said, I'm seeing your patient, and I think we should do this, and I'll call you back after. I keep following him up. I'm like, you're going to follow him? So I really appreciate what he does, and also Dr. Shantanu, who's at the VA. These two are awesome gentlemen, and they're going to talk us through PAE.
All right. I do have clinic. It's a very busy clinic. Nice to meet y'all. I'm Shantanu Warhadpande, one of the IR attendings, and it's nice to see a lot of familiar faces. I was joking with Dr. Palapatu that I think I know more urologists than I know radiologists. So it's a green button. No disclosures. I wanted to start off with a couple acknowledgments. The whole reason I'm here and this entire talk would not be possible without the help of several particular doctors that I work with very closely in the BPH space, Dr. Wei, Dr. Dow, and Dr. Pugachetti. So thank you all for collaborating. And I think the most unique part about Michigan medicine, and it is unique, I've been at 4 different hospital systems, is the collaborative spirit. And I think that is something we talk about very a lot in medicine, but I think we really embody that. So the relationship that I've formed with the urologists here has been one of the most professionally gratifying things about my job. So thank you to all 3 of you and all the other doctors that I worked with here. For the non-football fans, on the left there is Justin Tucker, and on the right is Martin Gramatica. So Justin Tucker is super, super well-known, very, very good kicker. On the right is Martin Gramatica, who tore his ACL celebrating a routine 35-yard kick. I share these pictures because I think that IR is a lot like NFL kickers. You know, there's a lot that NFL kickers do that is no one pats them on the back, and nor should they. You know, go out there, kick your field goal, kick your extra point, and make it. That's your job. Similarly for IR, there's a lot of things we do that we don't expect or should get a pat on the back. Enough tubes, SB tubes, biopsies, and so on. So I tell my fellows this every single year, and some listen, some don't, but be Justin Tucker. Don't be Martin Gramatica. You want to be the guy that usually he makes all his kicks, but then occasionally you'll be called upon to get that game-winning 50-yarder or 60-yarder, and that is when you get to go in and shine. So be Justin Tucker. That's neither here nor there. Oh, sorry about that. All right, so this is a topic that I'm very passionate about, and I'll get to why in a few minutes. But PAE for me is sort of the apex IR procedure, right? It's the perfect marriage of clinical medicine. I see all my BPH patients or my PAE patients in clinic beforehand, and then I follow them for about a year afterwards. So you have the clinical side, you have the procedural side. This is a very, very challenging procedure, a very gratifying procedure when you do get it and do it right. And additionally, it's this perfect blend of procedural skills and imaging knowledge. And I'll show you some images which are very complex in terms of how you navigate that imaging. So thanks to the collaboration with Dr. Dow, Dr. Pugachetti, Dr. Wei, Michigan Medicine VIR has done probably the most PAEs in a lot of academic centers in the last 2 years. So we're averaging about 6 to 8 PAEs a month right now, and that makes us, like I said, one of the highest PAE volumes in academia around the country. We have had very good success. So I would say 90+% of our patients are technically successful. We do have a few patients here that we couldn't get. Only one patient I can think of in the last 2 years that I couldn't get either side, but and then a handful that we haven't gotten both sides. One thing I'll mention here, you have to get a bilateral embolization for it to be considered, in my book, technically successful. Unilateral is not going to cut it, even though sometimes it does work. Similarly, your clinical success has been fantastic. It's over 80% improvement and meaningful improvement in IPSS and quality of life scores. And then I share this because this is sort of the most, I think we were talking about, placebo effect. This is a very clear example of this working. So we have, I've had 11 patients from both urology and from around the state that have been sent for retention. And we did PAEs and obviously massive prostates. And 9 of 11 are catheter free now. And we usually do voiding trials starting at the 1 month mark, 2 month mark, and then 3 month mark. And if all 3 of those have failed, then usually they go back to Dr. Dow, Pugachetti, or Wei for a whole lot. So all that to say is that thanks to this success, thanks to that collaboration, we're now starting a multidisciplinary clinic at Chelsea Hospital between Dr. Pugichetti, myself, Dr. Dow, and Dr. Wei for large prostates. So we can talk about that later if you'd like. All right, so I'm going to jump into this with a case. This is, I don't know if Dr. Schuster's in the room or not, but this is one of Dr. Schuster's patients that he sent to me recently. So gentleman with a massive prostate and a suboptimal surgical candidate. So he'd had a Foley for a little bit of time, and when he came to see me at that time, he had considered surgery versus some other stuff, but 460 cc prostate. And really the only option for this gentleman was prostatectomy versus something else, aka PAE. So, my pitch was, let's try PAE first. If it doesn't work, then we can obviously go down the surgical route. So this is his prostate. Again, massive, probably the largest prostate that I've seen, having done a lot of these now. I start with this case because I think this is a good example of sort of the power of PAE. I do my PAEs the same way every single time. It's the same steps, and I believe that I have a very good protocol set up that's safe and effective. So groin access, I don't do radial, always groin. So groin access, internal iliac, IPSI first, then contra. Identify and get into the prostatic artery, which is the hardest part of the procedure, followed by intraprocedural cone beam CT. Now, this step right here is what separates us from pretty much every other hospital that does IR PAEs. So cone beam CT adds extra time to the procedure. It's an intraprocedural CT that you have to do to confirm that your catheter is in the prostatic and your contrast you're injecting is going to fill the prostate and nothing else. No rectum, no bladder, no pudendal, and so on. I'm not sure why people don't do them routinely. I do them because that allows me to look at the patient in the eyes and say, I'm not going to get non-target. So that is how I confirm that. I embolize with 300 to 500 micron particles, which essentially there's no risk of necrosis. You have to get sub 100 micron particles for necrosis. So 300 to 500, no big deal. And then repeat the steps on the other side. So this is what an internal iliac artery angiogram looks like. I don't know how many of you have you seen, but this is sort of what we see. It's very complicated looking when you first look at it. I've marked out the prostatic there. And this is where the technical challenges come into play. So when I'm looking at this, the first thing I'm noticing is that I have a reverse curve catheter that's snaked into the internal iliac, and that prostatic is coming off. It's a 180 turn. Having done a lot of these, there's no way that an IPSI axis is going to be a good enough system to be able to get into this. So you get contralateral access. You go up and over from the left. You park your sheath. I've marked that there on the 6 French sheath up and over. You get a smaller catheter coaxially into the internal iliac, and then a 2 French microcatheter through that allows us to get enough pushability and torqueability to get deep into the prostate. This is the prostate artery angiogram. So you see a nice little blush of the hemiprostate there. And this is what I was talking about. So the intraprocedural CT is what allows you to confirm that you're getting prostate and no rectum, no bladder. And this is sort of the most dramatic prostate that I've seen, hemiprostate that I've seen. And then here's the other side, the left side. And this is exactly what I want to see. I want to see the entirety of the prostate, plus or minus median lobe if he has one, pacify, and that allows me to very aggressively treat and embolize. I mentioned earlier that this sort of flexes the power of a PAE. It's the same day discharge. So the patient came in the morning. This was about a 2.5 hour long procedure. He was home by about 1:32 p.m. We did it with moderate sedation, and he had a voiding trial, I think, a couple months later, and then he passed that with a decent PVR. And then he saw me, I think, in July or August, or early August. And that IPSS, I apologize, is wrong. It's 8. It should be 8. But he, as far as I know, he remains catheter-free. Is that correct? Yeah. He's super thrilled about this. So I wanted to start with that case because I think it's a dramatic example of what a PA can accomplish, sort of a real-world example from one of our colleagues in urology here. So quick background, and I'll jump into a couple cases as well. So PAE first was introduced to the urology world in the early 2000s for hematuria, specifically cysto-confirming that there's nothing else that's bleeding, make sure that it's only prostate, and then call IR. So what they noticed was that in addition to the hematuria improving, they were also seeing that the LUTS was improving as well, that the patients were seeing in clinic, and there was improvement in their IPSS. So that led to the first large RCT out of Portugal in 2010, which then showed kind of gave us more promising results and was the first introduction to the IR world that, hey, this can be potentially done for BPH and not just hematuria. So the first 10 years, I would say, of the PA being sort of in the IR and urology world, we had terrible studies, and that's partially because of my specialty. IRs are not researchers. We're terrible at research. And the studies were poorly designed. They were not good studies. Most of the studies are coming out in IR literature, which no one here is going to see. So a lot of issues there. But for some reason, IR kept pushing for it. And this is, by the way, a natural history of all IR procedures. This is normal. We're used to it. This is what we should be doing, right? Collaboration, not talking in a little echo chamber. In either case, as would be expected, PA was met with a lot of skepticism, and it was very controversial, understandably so. And then 2017 was when the first real good studies started coming out from Sweden and from Europe. And these were actually well-designed studies that were published in reputable journals. So I'll show you a couple of those. But that did show that, hey, it actually works, and there is a role for it. And now, from 2018 to now, we're trying to figure out where PAE fits into the BPH management algorithm. So in the last 6 years, there's been a lot of big progress being made in the PAE world. So we have FDA approval as of 2017, I believe. Insurance starts covering it. So I've thankfully had not a ton of pushback from insurance. And then as of 2023, just last year in August, it was included in the AUA guidelines for BPH. So again, just kind of hammering this in again and again. It's a same-day procedure, quick. It's an outpatient procedure. The more you do, the faster I've gotten. I can do these in about 2.5 to 3 hours now. Foley's placed for the procedure if they're not in retention, and they would remove it the same day. We do this with light or moderate sedation. I've done a couple in the last 2 weeks, actually, with no sedation at all. So the gentleman was wide awake, and we had horrible music playing that he requested, just to calm him down. And then they returned the same day return to ADL. So we had a couple. I had a professor I treated a few months ago who did it on his office or academic day or whatever, and he was teaching the very next day. So. And then the side effect profile is very favorable. Really, there's no risk of neurovascular bundle injury. There's essentially no risk of sexual dysfunction as long as you're not, shooting it down the pudendal. And the real risks are pretty much from the access site, which is the groin access site. And the clinical efficacy, and this is consistent with kind of what we're seeing internally as well, is 80 to 85%, 50% reduction in IPSS at the 3-month mark. And that brings me to the first disadvantage, which is that it's not like a whole lap or a TURP where the patient walks out of the hospital feeling better. It takes a while, and I can't guarantee that they'll be 50% better. I just can't. I think they will. I'm cautiously optimistic with every patient I talk to in clinic, but I can't guarantee that. And sometimes that matters to them, and they don't want that. They want the guarantee. They want to be able to walk out of the procedure knowing that they're going to be better. This is technically probably the hardest IR embolization that I'm asked to do. The prostatic artery is tiny. It's sub 1 millimeter. It's hard to identify, hard to get into. And we have a lot of different tools and ways that we can plump up the artery. We can give nitro and verapamil and so on. But you need to have someone that's doing a lot of these. And the reason why it's not widely adopted and being done the right way, and that's a big thing that I talk about, doing it the right way, because there's a lot of IRs doing it the wrong way, which is quite upsetting. But doing it the right way, you need someone who's doing it a lot and doing it at a place like Michigan where you're seeing 7, 8 a week. And then finally, it takes a while for the effects to kick in, 8 to 12 weeks. So some patients don't really want that. So these are the good studies that I was mentioning to you all earlier, which is starting in about 2017, we started getting high impact journal publications in high impact journal. So this one's in European Urology, which is far more high impact than JVIR. And this was a sham study. They looked at PA versus sham, where they would catheterize the prostatic artery and then just inject saline as opposed to particles. 80 patients, about a year follow-up. And as per usual, they looked at IPSS quality of life. The one thing I'll mention here, this is an important fact that differs from our practice here. They were looking only at moderate-sized prostates, so 30 to 80 cc's. We essentially are treating large prostates here. We're not doing moderate-sized, and I'll get to why in a few minutes here. And the results were very positive. It shows that there's a 50% drop in PAE or IPSS after a PAE, and then when the sham patients were when they were open extension period, they were able to get a PAE. They saw a similar drop in IPSS, and it was statistically significant, and very few adverse events. Ironically, the one serious was in the sham study at the groin axis site. So kind of moving on, BMJ, that was the biggest, highest impact journal that we have gotten a publication in. This was by a European urologist, of course. And they looked at, again, moderate-sized prostates, PA versus TERP. And here, I'll just summarize this very quickly. They both saw a reduction in IPSS. TERP did do a little bit better. And in TERP, the effect, the IPSS drop was almost immediate, obviously. With PAE, it took about 3 months for us to get to that point. And it was not statistically significant. That's the only sort of downside of this. But from a urodynamic standpoint, TERP was far, far superior to PAE. So if the patient has significant issues like Qmax or whatnot, PAE is not the answer. And I almost wish I would have included this. They included mild pain in this, which is why it looks so bloated, the adverse events. I'm going to move on from that. This is more of the same. This is kind of just showing the same thing. TERP and PAE, they're similar. TERP is slightly better. But again, every one of these studies just kept looking at moderate-sized prostates as opposed to large. So that's my biggest criticism of a lot of these studies. But in terms of the data and the results, it's all about the same. The TERP and PAE both work. TERP is slightly better. I'm going to just go through these quickly and get to the cases. So here are my takeaways from literature. And I've spent probably the last 4 or 5 years devouring every single article that comes out on PAs. And the takeaway here is that PAE works. I still believe for moderate-sized prostates, small and moderate-sized prostates, the transurethral procedures are probably superior. So I don't love that. That's the reason why I don't like to do PAEs for small and moderate-sized prostates, less than 80. When it comes to side effect profile and the highly anxious patient who really does not want anything stuck up their penis, PA is the answer. I think that is a patient who should be offered. Or if these are patients who are languishing on finasteride and tamsulosin and they really don't want anything else done, consider PAE. My personal experience, having done, I've lost count at this point how many I've done in the last 2 years. PAE works very well for large prostates when done well. Bilateral embolization, thorough embolization, do a cone beam to make sure you get the median lobe if they have one, or large median lobe if they have one. And so do your due diligence. It does add a little bit of time, about half an hour extra to the procedure, but just do it right. Knock on wood here, I have not had any major complications. I had one pseudoaneurysm in the superior gluteal that we caught and we treated right away. But thankfully, I've had no major side effects or complications and no sexual side effects in our patients. PA is very challenging for small and moderate-sized prostates, to the point where I almost don't even want to offer it to patients anymore. So, me and Neil have been talking a lot about sort of inclusion criteria for this clinic of ours. And to be honest with you, I almost don't want to even consider PA for small and moderate-sized prostates. So there are some patients who absolutely will self-refer to me and they absolutely want it. I'll consider it, but I will warn them in clinic that this is going to be hard. I may not get it. And if you're still okay with proceeding, we can, but let them make that decision. On the flip side, PA is very, very straightforward for large prostates. The arteries are just bigger, relatively speaking, and easier to get into. So I'm going to show a couple cases here. These are all, again, large prostates. So this gentleman was 78-year-old with hemophilia on Amicar, 364 cc prostate. Obviously, with the bleeding risk, he was going to be a HOLIP candidate, but with the bleeding risk, he seemed like a good PA candidate. So here's a pre-procedural CTA. I do like to get a CTA before all of my PAEs. That's something that I sort of insist on if possible. It makes my job so much easier to identify and get into the prostatic artery, just knowing where they're coming off. So here the CT is coronal and axial. It's a large prostate, and I think I had the prostatic arteries marked. So that's what they look like on the CT. That's what I'm looking for. They always sort of course anteriorly and come in to the prostate at sort of the 10 o'clock and 2 o'clock position. The other thing I'm looking for CTA is presence of athero, if there's tortuosity. These are all old patients, right? So their vessels are uncoiled. Sometimes it's just hard to go up and over, so you got to get the radial access or bilateral groin access. So those are all the things I'm looking for a CTA. So just to show you the complexity of an internal iliac angiogram, this is what we see. So we got to find the prostatic into this. So there's, again, ways that having seen a lot of these, I can look at this and identify the prostatic right away. But I don't know if I have marked, but it's the loopy one that's right next to the, whatever, it's fine. There it is, there, I'm in it. And you see the hemiprostate blush there. So that's what you're looking for. And again, cone beam CT to confirm that you're getting hemiprostatic blush. And I'm actually less looking at the prostate here. I'm more looking at the rectum, the pudendal, and the bladder. A lot of science that goes in behind embolization and choosing your particles, choosing your size of the particles, which I'm not going to get into, but I'll summarize by saying 300 to 500 micron particles, you can be extremely aggressive, and even if you get some non-target into pudendal or rectal, there's enough collateralization in the pelvis that it's not going to do anything. This is very different than what nationally IRs do. They do 100 to 300 microns. I found that I can't sleep well at night when I do 100 to 300s, because if you get it down to pudendal, which is an end artery, dorsal artery penis, which is a end organ artery, you will get penile ulcers, tip of penis ulcers. So I can't sleep well at night, 300 to 500. I've had very good results. I'm going to keep doing it. And this is what it looks like after I've embolized, and you're not seeing that blush anymore. You're getting a decent amount of reflux. This is the other side, just kind of more of the same. Oh. Is there a mouse? No. That's fine. Bottom right, can you click the, can you hover over and press play? That's fine if you can't. We can move on. That's fine. There you go, yep. So again, just to give you guys a sense of how complicated the pelvic anatomy is, I included this example because you see the inferior rectal there going down and you see rectal blush. No matter how hard I tried, I could not get my microcatheter to go into the prostatic. So this was a common origin of the rectal and the prostatic artery. In that case, there's a lot of advanced techniques we can do. So in this case, we can coil off the rectal artery, the inferior rectal artery. As long as you coil it off proximally, there's enough collateral flow from the superior middle, which is IMA territory, that you're not going to cause any issues to the rectal. And then once you do that, you can get good hemiprostatic blush. And obviously on your, this is when you cone beam. So that's what it looks like post-coiling. You're seeing an prostate. And this is where you absolutely need to do a cone beam to confirm that you're not getting rectal blush. And in this case, we don't. You see good hemiprostatic blush. And that's the coronal. And that was satisfactory. So we aggressively treated with 300 to 500 micron particles. So, and this is pre and post. You're going to see some veins pop up right there. That's an endpoint. So that's our endpoint for embolization. So a lot of fellows ask, when do you know when to stop? When you see venous return, that's when you stop. So saw him in clinic about a month later, no issues, but way too early to do a voiding trial. It takes about 2 to 3 months for the PA to really do its job and have meaningful reduction in volume, prostatic volume. And at the 3-month mark, he passed and has done great since. I saw him in clinic about at the 12-month mark a few months ago, and he remained catheter-free. And IPSS was 3, so he was very happy. And then I think one more, there's the last case here. So this gentleman was not in retention, just a gentleman who really, really did not want anything transurethral done. And only sort of relevant history was AFib with RVR and Eliquis. But the prostate size wasn't as big as those other 2 gentlemen, but IPSS was 24 and he was severely symptomatic. So again, more of the same. I'm going to go through these quickly. And the reason I included these was just to kind of give you guys a sense of just what I'm seeing when I'm in there and kind of the complicated nature of it. And I've listed out the anatomy there. Anterior posterior division branches, obviously, and the prostatic is labeled as well. So I had to special order a lot of these tools to be able to get into the prostatic every single time. So the True True Select catheter is a very specialized catheter that is meant for PAs. It's a braided micro catheter, so very, very nice, great pushability. But we had to special order those just for PAs. So thankfully, Michigan Medicine acquiesced, and we have a lot of those in stock now. And again, cone beam CT to confirm. Was discharged the same day. So his big issue was his big issue was nocturia. So 4 to 5 times, and this symptom, and I'll get to in a second, is a very near and dear to my heart, and you'll see why. But at the 1 month, his IPS had dropped 50%, and at the 3 month, it had gone to 5, and he was waking up only at most 1 time a night. I mentioned this, the embolization. The reason why this is hard is because the artery is small. So I give a ton of intraarterial nitro. So sometimes you have to load them up with midodrine just to be able to accommodate the amount of nitro we're giving them to give them a buffer. So we give them mido, and then we give them nitro, 400 of nitro sometimes, so massive doses, just to be able to plump up the prostate artery. We also give them verapamil, and the vasodilatory cocktail that we give them is meant for 2 things. Number 1, obviously to make the artery bigger. But number 2, if there are small branches that are going to the pudendal and rectal or vesicular, which they're always, creating this low vascular resistance bed in the prostate is actually protective of those small branches. So I've started doing that in the last year or so, and it's worked out really nicely. The goal here is ischemia, right? We're not trying to cause necrosis. So as I mentioned earlier, sub 100 micron particles, you get necrosis. 3 to 500, you're not going to get ischemia. You're going to get ischemia, but you're never going to get necrosis. And you can tolerate non-target a lot more just because there's such good collateralization in the pelvis. Patients are discharged the same day as long as they can pee on their own. About 3 to 4 days out from the procedure. So all my patients get my cell phone number for this reason right here is they almost all have, if I do a good job, they're going to have sterile prostatitis. They're going to have burning on urination. They're going to have urinary frequency. Sometimes they're going to have post-embo syndrome with low-grade fevers. It's expected. And I kind of hammer that in the clinic the day of the procedure. And then I also check in on them the night of or the night after, the morning after, and let them know that this is all normal and that there's treatments for that if it's bothering you a lot. As soon as they're over that little hump, they start seeing improvement within the first week or so. I would say majority of my patients see some degree of improvement at the 1 month mark, and then definitely at the 3 month mark. So my ideal patient. This is my personal opinion. You're going to hear, depending on where the trainees go, you might have IRs that are treating small and moderate. I just don't think it's worth it. I think you guys can probably do a better job at treating small and moderates than I can in less time. So for me, I want large prostates. PA for large prostates works great. I want a CTA that doesn't show any vascular disease, which thankfully I've had to turn down only a couple patients because they had such awful vascular disease. And of course, poor surgical and anesthesia candidates. These are the patients that are in retention. Maybe they can't get surgery or anesthesia. Send me those patients. And then of course, any patient who does not want anything stuck up their penis or anything like that. So, or high anxiety about any procedure. So what's next? As I've kind of mentioned, I don't think it's worth doing for small and moderate. I don't think I particularly want to go down that route. Some IRs might, I don't. And for me, I would love to get more patients that are sort of on medication for a long time that perhaps HoLEP may not be an option. HoLEP is not offered in that hospital. Those are the patients that I think PA would work for. I think we have a good sort of cadence right now with the HoLEP surgeons here. I think it's been working out nicely, and I'm very grateful for that. And I think this is sort of more of the same here. I almost hesitated including this last point here, but I really do think that in the modern day of all these minimally invasive therapies available for BPH, it doesn't make sense to me to offer a prostatectomy when PAE is available. And this is a major abdominal surgery, and in my opinion, trial a PAE first. If it doesn't work, then absolutely take the patient to surgery, but give that a shot first. And if it's successful, it avoids a major surgery. So this brings me to my kind of final point. What would you recommend to your dad? That's sort of what we always are asked, right, by patients. So what would you tell your dad? So this is my dad and I. For about, growing up, we would love to go to movies together, theaters to go watch movies. In 2012, 2013, he just, cold turkey stopped going. didn't want to go anymore, and I noticed he was napping a lot during the day, and I was kind of bummed out, but I was like, well, I'm getting older, I'm in med school now, maybe he just doesn't want to go watch movies. And then my mom told me that it's because he kept going to the movie, or he kept going to the bathroom every hour, every 2 hours. He kept falling asleep during the movies, so he just stopped going to movie theaters. So he has BPH, or had BPH. He had a 220 cc prostate, and he was seeing a private practice urologist in Chicago area, and he offered him, he'd gone through all the medical management and wasn't working anymore, and finally offered him a prostatectomy. And this was back in 2021. And I had stayed out of my dad's care, urological care, for a long time. I didn't want to be the guy that, pushed for something, and I was clearly biased. So I didn't want to push for a PAE, but finally when the option of surgery came on the table and they were starting to make plans for the surgery, I said, okay, no. Well, let's back it up. Let me send you to the guy that taught me how to do PAEs in Northwestern. Try it. If it works, great. If not, then by all means, go get a surgery. And it worked. The PAE worked beautifully. 3 months later, in July of 2022, we watched our first movie in about 10 years together, which was Top Gun. Great movie. He stayed awake the whole time, didn't have to go to the bathroom until the very end, and then he rushed out and peed like a racehorse. So thank you. Thank you all for having me here. This was a real pleasure.
Thank you for that excellent talk. I confess I send just the kind of patients that you described to I'm at Vanderbilt, and those patients have done very well. My question to you is, what are the radiation doses that you can, because you're doing a CT angio, then you're doing a 2.5-hour procedure.
Yep.
And I'm sure it varies, but what would we tell patients there?
Yeah. So I live and breathe in radiation, right? So the radiation dose to the patient is negligible. It's a decent amount. Don't get me wrong. It's about 2.5 gray, which is a lot. For a single session for that patient, it's not going to do anything. For me, it's a bigger issue. So we had to buy our own movable shield to protect me. So whenever patients do ask that all the time, right? What's the radiation dose? And my answer is always, it's a bigger issue for me and my fellow than it is for you. In a single session, 2.5 gray is not going to do anything. But for me, I'm doing at this point, on Monday, I think I have 3 PAEs already. That's 7-8 grays of radiation for me. So it's a bigger deal for me than it is for them.
Hey, Shantanu, that was a great talk. Just what are your thoughts on median lobe? How do you approach that? Is that an exclusion criteria?
Yeah. So some IRs will tell you that sort of the ball valve effect, you got to be worried about that with the PAE. I have not had a single patient unable to pee after a PAE. I've not had any patient go into retention. Part of that is also because I load them up with so much anti-inflammatories. So I give them pre-procedurally Decadron, intra-procedurally 30 of Toradol. Post-procedurally, they're on NSAIDs pretty much for 3-4 days. So keeping that in mind, that's exactly why it's less for pain. Patients will ask, is it for pain? And my answer is no, it's more for the anti-inflammatory, because prostatitis they already have a narrow urethra. It's going to shrink down even more. I have not had any issues with median lobe enlargement. Yeah.
Yeah, one question.
Hi. We have a patient we actually just sent for a PAE, so this is a very interesting talk to hear about. My question is, what is the long-term data on how long these patients last without needing an additional intervention? Yeah. And the other question is, after the PAE, are most patients getting to stop their BPH medications, or is it a combination of the both?
Yeah, so that's a really good question. So we have, and patients ask that almost every single time I see them, we have good 5-year and 10-year data. We don't have anything past that, only because this has only been around for 15 years, 16 years. I've had 2 retreatments. One that was treated, one of the original patients treated in Portugal in 2010, and one other patient who I treated in 2022, very early on. And my concern with those patients is always, because we're embolizing their prostate, how does it change their vascular signature in and around the prostate? And the answer is, surprisingly, the body will recanalize all those vessels I'm shutting down. So eventually the body will recanalize. They will reform, angiogenesis will do its thing, and it will form vessels again. My hope is that with these patients being what their age is, that we've bought them enough time and enough of a buffer that we've given them at least 5 to 10 years. But that's usually what I tell patients is I can, based on the literature and data that we have, I can give you 5 to 10 more years.
So great talk. We've had a ton of fun kind of collaborating and seeing this grow. I think one of the things that made me real comfortable sending you patients right away is you should be commended for the follow-up that you provide these patients. It's probably better than I give them in my office, so that's appreciated. My question for you is, if you look at the sham-controlled and the non-placebo-controlled trials, there's like a 20% non-responder rate.
Yep.
And so my question is that, should that be bucketed into, technical failure? Or is there just something that we don't understand about a technically successful bilateral PAE and why 20% are not responding? So what I can tell you, to contrast this with HOLEP, is we have 100% response rates. Now that's not to say that the postoperative recovery may not have some, untoward characteristics for patients, but that's not something we see.
Yeah, absolutely. So part of my big issue with that sham-controlled study is that they included unilateral as a effective embolization. That is not true. You have to get bilateral. And I think we've had a couple patients that we've gotten lucky on with the unilateral, but I think you need to do bilateral, but they did not separate those two out. And so I have no idea whether those non-responders were just a unilateral or was it a shoddy embolization. Sometimes when we're embolizing, just the way the vessel might spasm down, despite this vasodilatory cocktail, it might spasm down. So you can bill it technically as a successful embolization, but you didn't actually embolize anything meaningfully.
So no good conference is complete with a question that's actually a comment. So I'm going to offer you a comment, and actually it's a compliment, which is Casey actually started talking about this already, but my compliment is in terms of your clinical skills and your commitment to the patients and your commitment to partnership with us in the room. I've been on call and you've helped me with an incredibly unique abscess around the kidney that I'm not sure other people would have wanted to help with. Lindsay Harrell, who was here earlier, told me a story about a partnership that you and her did at the bedside in the ICU with a patient. And so I just wanted to, the way we change the culture in medicine is by celebrating the people who we think are role models for what we think professionalism look like. And I just wanted to, as a compliment and a comment, say thank you for your professionalism and thank you for your partnership here.
I'm blushing. Thank you. You can't tell, but I'm blushing. Thank you.
I'll attest to that. He answered his text from me on vacation in Hawaii.
Wrote to Hana.
Great talk. I learned a lot, and it's always awesome to seeing how other specialties deal with the same problems that we have. But I had a question. Do you have any absolute contraindications to the procedure? And I imagine you give a lot of contrast during this process. You have issues with patients with renal disease and whatnot?
I don't believe in CIN at all. Give contrast. Give all the contrast in the world. Yeah, I don't believe in CIN. The old non-isoosmolar contrast agents were definitely the problem, but the newer agents in the last 10, 15 years, IsoVu, Visipake,
This will be the last question, then we'll go to break.
Would you consider a patient that we might have on watchful waiting, that we're not going to offer, surgical intervention for prostate cancer? And would you consider?
Yeah. The prostate cancer, you said it's prostate cancer patient? Low grade or? Yeah, for what it's worth, my dad has 3+4, so I think, right? But no, he is low grade as well, so he did fine. Yeah. I think I forgot to answer your question about the absolute contraindications. For me, the two big ones are vascular anatomy, the CTA being very helpful with that. And that's not, these are all old patients with terrible old vessels. So if I sense that I'm going to have a lot of difficulty getting in or just navigating through the iliacs, then that's probably the biggest thing. So it's an anatomic issue. Okay. Thank you
Thank you very much.